This talk is intended to give you an overview of how to give a good oral presentation. It's designed for preclinical medical students who are about to start their clerkship rotations, but it can also serve as a refresher for senior med students and junior residents. It's geared towards an ER consult on a general CTU rotation, but the principles covered here can be applied to presentations for various specialties, and hopefully will set you up for success throughout all of your clerkship rotations. To start off, we'll go through some fundamentals and general pearls, then we'll take each section of the presentation and break it down, and finally we'll give you an example of a bad presentation followed by an example of a good one. And as well, you can find links to a written guide to the oral presentation, as well as annotated copies of the presentation examples in the description. So why do we care about the oral presentation? Well, first and foremost, it's because it's an integral part of patient care. We use the oral presentation every single day to hand over our patients to other physicians. Oftentimes, our patients are really complex and we're under a big time crunch, and so we need a way of communicating information that's standardized and that's efficient and effective. Handover is one of those critical moments in medicine that's prone to a lot of error, and so for the sake of good continuity of care and patient safety, it's really important that as future physicians, we try to master the skill of presenting our patients. In addition, the oral presentation is your main way as a trainee to demonstrate to your team that you have good clinical reasoning skills. Because of this, it's really used as one of the main components of your evaluation as a medical student. You can take the best history and do the best physical in the world, but if you aren't able to articulate your findings in a good presentation, you're simply not going to receive the credit that you deserve. So both for patient care and in order for you to shine as a medical student, it's extremely important that you learn how to present well. So you've all seen this. This is the basic structure for presenting a consult. And I know that many of you watching have not yet seen your first consult, and we tend to throw that term around a lot. So what that means exactly is this is how you will present a patient that you have seen for the very first time. This isn't how you're going to present your daily progress reports on the patients you've rounded on that are already on your ward. That will be more of a SOAP format. So this is for consults or new patients. Now, there are going to be small tweaks for different specialties, or you'll even find that different residents and different staff will want you to present in different ways. But what I'm presenting here is the most basic form of the presentation, and I think that the principles we cover here should give you a good foundation for presenting patients and will set you up well for the majority of your clinical rotations. All right, so let's get into some general principles of presenting. These are things that you should always try to keep in the back of your mind when you're getting ready to present any patient. So we'll keep it simple. Number one, imagine that you're talking to a busy attending at 3 a.m. Number two, tell a story. And number three, you are an editor, not a tape recorder. So when you're presenting, try to imagine that you're talking to a busy attending at 3 a.m. Quite literally in medicine, oftentimes you're going to be presenting at some ungodly hour in the middle of the night where both you and your resident are tired, stressed out, impatient. And so whatever you say needs to be extremely clear, succinct, and easy to listen to. And this is the approach that you should have for every presentation that you give, regardless of what time it is. Few things in the world can put someone to sleep faster than listening to a long, rambling, repetitive presentation. And perhaps you've already fallen asleep during this one. But in any case, when you are presenting, try to be engaging, make eye contact, be expressive with your voice, and ultimately, just be cognizant of the other person's time and attention span. I think a good way to think of the presentation is like giving an elevator pitch to the CEO of a big company. You got this very limited amount of time to convey important information while capturing and holding the attention of your very busy listener. So, when you're presenting, imagine that you're talking to a busy attending at 3 a.m. Principle number two, tell a story. Tell your patient story. Your presentation shouldn't just be you reading off your notes or giving this big list of symptoms and signs. You should instead think of your presentation like the plot of a movie or a novel. There needs to be context, a setting, a clear sequence of events that makes sense. And the protagonist of your story is your patient, and you're giving a well thought out, organized, engaging narrative of their illness. Now, this is a crucial point that I really want to hammer home, and if there are only a couple of things you'll take away from this talk, this should definitely be one of them. So, in your presentation, the conclusion, or the big punchline that you're leading up to, is your differential diagnosis. Think of your presentation like the plot of one of those really bad, cheesy horror films, where even at the very beginning, you know exactly who's going to die first, and you know who's going to survive. In your presentation, even from the very first sentence, every single thing you say should point to or foreshadow your differential diagnosis, so that by the end of your presentation, your differential should be so blatantly obvious to your listener that they can already guess what it is, even without you having to say it. Another way I like to think about the presentation is that you're trying to paint a picture. You're trying to paint this very accurate portrait of who your patient is and why they've come to hospital. And what you want is when your staff actually goes to see the patient, they walk into the patient's room and say, yes, this is exactly who I was expecting to see based on the presentation my med student gave me. What you don't want is for them to be totally blindsided, caught off guard, because the patient you presented versus the patient actually in front of them are two very different people. And finally, within your presentation, there shouldn't be any big surprises. So for example, you shouldn't present a patient who has abdominal pain and bloody stools, and then 10 minutes into your presentation, drop a bombshell and tell us he's all 5 days post-op from a left hemicolectomy. Or if you've got a patient with shortness of breath, don't wait until the end of the past medical history to tell us that he has HIV. You know, in your presentation, you want to think Disney, not Hitchcock. Think history, not mystery. And finally, our last big pearl, when you're presenting, you're an editor, not a tape recorder. That is, your role isn't to regurgitate word for word exactly what the patient told you when you were taking their history. Your job is actually to take all of this raw data, process it, and turn it into an easy to digest, coherent story that directly points to your differential diagnosis. This will involve rearranging, rephrasing, and sometimes actually cutting things out altogether. And that's okay. That's what you should be doing as a good clinician, as long as you're still giving a truthful, accurate account of your patient's history. And along the lines of rearranging, another really important principle is that you can move things from other sections of your presentation into the HPI if you think that info is really important in understanding your patient's current visit. We'll touch on this more later, but please don't feel like it's incorrect or improper to move important details from, say, the past medical history or the labs into the HPI when it's indicated. And finally, perhaps the most important skill in presenting a patient is the ability to prioritize information and to present what is relevant. This is a really tough skill and it's only going to come with experience, but I think right away the easiest way to do this is just to say what you think is most important first, what is less important after, and to omit things that aren't important at all. And this should be done for every single patient, every single section of the oral presentation. So when you're presenting the past medical history for a patient with cardiac chest pain, mention their cardiac history first, before you go into their GERD, and before you go into their anxiety. And maybe don't even bother mentioning at all their uneventful cataract surgery from 20 years ago. Or when you're giving a differential diagnosis, give the most likely and the most common diagnoses first, and then you can list off some of the zebras at the end. This will make your presentation much clearer and easier to follow, and it'll show that you know what's relevant and important. So, be an editor, not a tape recorder. All right, those are our 3 big principles. Try to keep these things in the back of your mind as you're presenting, and you will immediately become a more effective presenter. So just before we start getting into each section, I want to make a quick note about taking notes. So I know that many of you watching haven't yet seen your first consult, so I just want to give you a quick rundown of what this will look like. So usually on CTU, you'll be on call. After your usual day of rounding and seeing the patients on your team's list, you'll head down to Emerge where there'll likely be some new patients for you to see. So you'll go see your resident and they'll say, all right, go see Mr. So-and-so. Say, okay, then you go look through their chart and their EMR, and then you'll go meet them and take their history and do their physical exam. After you've done this, you're required to provide written documentation of your encounter with your patient directly in the patient's chart. And so this will be written in the same format as your presentation. So you'll start ID, chief complaint, HPI, past medical, etc. After you've seen the patient and written your note, you will then present your patient to your resident or your staff. So regarding actually taking notes and writing in the chart, I think there are two main strategies. So the first, many people will like to do their write-up while they're seeing the patient. So they'll be taking notes as they talk and do their history and physical. Other people will do most of their write-up after they've seen the patient. I think ultimately this will come down to personal preference, but for me, I really prefer to do my write-up after I've seen the patient. I find that I listen better and I just take way better histories when I'm not preoccupied by pen and paper in front of me. And then this also allows me to edit and reorganize all the information in my head before I actually go to write it in the chart. And so then when I'm presenting, in front of me, I have notes that are pretty much laid out exactly in the way that I would like to present them. So I can really use them as a guide. If I write notes while I'm seeing the patient, first I have to write things down in the order that the patient tells them to me. They'll be unedited. I can't do any of the rearranging in my head. And so when it's actually time to go present, in front of me, I have this really raw, messy set of notes, and I have to do a lot of the editing and reorganizing on the fly, which I'm really bad at. So I like to do my write-up after I've seen the patient. I will occasionally write notes while taking the history, but that's usually if the patient's going to list off a long list of meds, or if the timeline is real confusing and I just need to visualize it on paper. But otherwise, I like to do it after I've seen the patient. But try both and see what you like better. So now let's get into it. Let's take each section of the presentation and break it down, starting with the opening remarks. So the first part of your opening remarks is the identifying info. So who is your patient? Who are we dealing with? We're just giving a snapshot of who our patient is. So every single presentation is going to begin with the patient's age, their sex, and then a few of their most pertinent risk factors or medical issues. So I'll give you a couple examples. This is a 66-year-old male, smoker, retired shipyard worker. Or this is an 88-year-old female with type 2 diabetes, hypertension, and dyslipidemia. Or this is a 20-year-old G1P1 pregnant female who was previously healthy. Now, as I'm describing these different people, I hope you're already starting to think of different things they possibly could have. This is because even from the very first sentence, I want you to already be directing your listener towards your differential diagnosis. And so if I say something like, this is a 66-year-old male smoker, shipyard worker, I hope that I'm directing you towards things like lung cancer or asbestos-related lung disease. Or if I say 40-year-old female, obese, history of stones with a recent gastric bypass, I'm directing you to things like biliary colic, acute cholecystitis, etc. So even with the identifying information, you're already directing your listener towards your differential. Okay, moving on to the chief complaint or the reason for referral. So this is the reason your patient came to hospital or the reason they were referred to you. It's just an extension of the identifying info, and it's all part of your opening sentence. Again, and this is so important, your chief complaint should point directly at your differential diagnosis. So again, this is a 66-year-old male smoker, retired shipyard worker with 1 month of dry cough. Or this is an 88-year-old female with diabetes, hypertension, and dyslipidemia who presents with 3 days of shortness of breath. Or this is a 24-year-old G2P1 pregnant female presenting with 1 day of first trimester vaginal bleeding. Again, I hope even with these snippets of info, you're already thinking of a particular differential. And again, you're an editor and not a tape recorder. And so the chief complaint that you present is not always necessarily the same chief complaint that your patient states. And so what I mean by this is that, let's say you have a patient with pneumonia who told you that they came into hospital because they weren't feeling quite right, but you go on to take their history and discover that they've actually been having fever and a productive cough for 2 days. So when you go to present your patient, the chief complaint should be fever and productive cough for 2 days, not feeling right for 2 days. And finally, you must always give the duration of symptoms in your opening sentence. Again, you're telling a story, and just like a story taking place in New York in 1930 would look completely different than New York in 2019, so too does a patient with abdominal pain for 3 hours look very different than a patient with abdominal pain for 3 months. So always give the duration of symptoms in your opening sentence. So here are 2 opening statements for the same patient. The first one goes, Mr. Jones is a 62-year-old Asian man with a history of cirrhosis, MELD score of 33, child PU class C, who's had multiple admissions in the past year for ascites, hepatic encephalopathy, hepatorenal syndrome, variceal bleeds, who also has a history of hypertension, diabetes, dyslipidemia, CKD, cataracts, and BPH, who presents with bloody stools. The second one goes, Mr. Jones is a 62-year-old man with decompensated cirrhosis who presents with bloody stools for the past 2 days. So as you can probably guess, the second example is much better than the first. It's more concise, and it really focuses on the patient's current issue. The second one is very thorough, but it gets lost in all the details, which really ultimately distract from the chief complaint. And again, you must always include the duration of symptoms in your opening remarks. So the bottom line regarding your opening remarks, we always want to know who, what, and when. Who is your patient? What is their presenting complaint? And for how long has it been going on? Always include these 3 things in your opening line. Moving on to the history of presenting illness. This is the most important section in your presentation. Think of your presentation like a figure skating routine. The HPI is those big triple axel jumps where if you don't stick the landing, the rest of your team could be flawless, but it won't matter. In your presentation, if you want to shine, you gotta nail the HPI. Here are some basics of the HPI. I know you've heard these before, so I won't harp on them. But in general, I think that a good way to start off is by saying something like, Mrs. So-and-so was in her usual state of health until 5 days ago. This is a nice, clean way to begin the HPI. All of you know the OPQRST AAA approach to history taking. Use it for all your major symptoms. It's a good way to flesh out all of the details of their symptoms. And for more minor symptoms or associated symptoms, you can just kind of rattle them off. In general, you want to give your positives followed by your pertinent negatives, and you'll group them by system. So for example, let's say their big complaint was chest pain. You'll do your OPQRST AAA of their chest pain, really flesh it out. And then after that, you'll say, but there was no dyspnea, cough, or syncope. You're thinking of related symptoms that really change the way that you would think about their chest pain. And then if you also discovered that they had a headache and you wanted to highlight this, you would flesh that out, but then you would say, but there was no photophobia, visual change, weakness, vomiting. You get the idea. And a quick note about pertinent negatives. I find that this is kind of a point of confusion among a lot of students. Now, pertinent negatives are things that you actually expected to be present in your patient, but weren't. You expected them because you had a differential in mind, and certain things on your differential would be consistent with certain findings. But you asked about them and they weren't there, so they become pertinent negatives. This requires you to actually have thought about your differential, and it shows your listener that you actually thought about these questions and asked them. So, for example, if you saw a patient with a headache and then said there was no fever, neck stiffness, change in mental status, or rash, I'd immediately know that you considered meningitis in your differential. And another thing, before rattling off a long list of pertinent negatives, so you can group a lot of them by system, as we mentioned, but at the end of your HPI, you can cover all of those other pertinent negatives that don't really neatly fit into one particular system. Before rattling all of these off, I like to usually say something like, and aside from this, there were no other symptoms, and then go and list them all off. This is just a nice way to cue your listener that they don't really have to pay as much attention to what follows, and it gives them a break. So I think say something like this, it's a nice thing to do. And finally, no one wants to do math. Give your timeline in terms of things like days or months or years ago, instead of saying something like in April of 1945. This is just much easier to follow. But here's where I think is the more important aspect of the HPI. Remember, you're telling a story, you're telling your patient's story, and every good story needs context. It wouldn't just be enough to spit out the OPQRST of every single one of your patient's symptoms, because so much more of the history lives outside of this framework. So, for example, let's say you saw a patient with bloody stools. It would be really important to know whether this patient was previously healthy, or whether they just had rectal surgery for cancer last week, or whether or not they've had a normal colonoscopy recently. All of these things would greatly change the way you interpreted their symptom, and it would have been missed if you just simply stuck to the OPQRST AAA. I think a nice way to think about the HPI is that ultimately you're trying to answer this question. Why is this patient presenting with this symptom at this point in time? I think if you keep this in the back of your mind while you're taking your history, you will already start giving presentations that are more engaging and that give a more complete picture of your patient. Now, we touched on this before, but I think it's really important, should be emphasized. That is, if there's anything in any other section of your presentation, so the past medical history or the labs or the social history, that you think is absolutely crucial to understanding the current problem, it should be presented in the HPI, not in that other section. So, for example, if you're presenting a patient with a possible bowel obstruction, it would be crucial to mention whether or not they've had previous intra-abdominal surgeries in the HPI, as this would significantly impact your differential diagnosis. Or let's say you saw someone with an upper GI bleed, and their most recent hemoglobin was 60 compared to 100 a couple hours ago. Even though this is technically a lab value, it's really critical to understanding the severity of their bleeding and how urgently it needs to be dealt with, and therefore it should be mentioned in the HPI, not in the investigations. Again, you're an editor and not a tape recorder, so feel free to move things around in different sections if you think it's indicated. I know we touched a bit on pertinence or relevance before, but I think it's such an important concept that I really want to hammer it home. And so when we talk about things like pertinent negatives or pertinent findings, what we're really saying is, does this information change our differential diagnosis, or does this change the way we will manage our patient? In your first year, you're all taught how to take a history, but because you have little medical knowledge at this point, you're really just being taught a million different questions you could possibly ask your patient. But as you learn more medicine, you begin to realize that not all questions were created equal, and that it's really important to ask your patient with back pain whether they have a history of cancer or whether they use IV drugs, and it's much less important to ask them if they have a family history of inflammatory bowel disease. And what you'll also probably realize is that somehow your staff will be able to know much more about your patient and have a much better grasp of what's going on while asking a small percentage of the questions that you did. This is because your staff asked those questions that are absolutely the most relevant. As soon as they walked into the patient's room, they had a differential diagnosis in mind, and every single question they asked was targeted with the purpose of ruling in and ruling out the items on their differential. This is a skill that comes with a lot of time and experience, but even as trainees, I think it's crucial that we practice having a differential in mind and asking questions deliberately based on this differential. So that wraps up the HPI. Remember that it's the most important section of your presentation. Remember that you're telling a story. And lastly, focus on what is pertinent. Okay, moving on to the past medical history. So the past medical history can be broken up into your active issues versus your non-active issues. I think an easy way to think about this is if you've ever studied French, you know that there's two forms of the past participle. So you have the imperfect past. Those are things that started in the past but are still ongoing. These are kind of like your active issues. And then there's the passé composé. These are things that started and ended in the past. They're done. These are kind of like your non-active issues. So you can think about your past medical history in this way. Usually we care more about the active issues that are still affecting our patient. Sometimes the inactive issues are relevant as well. So again, your patient with a bowel obstruction, it's relevant to mention that they had an appendectomy, even though it was 15 years ago and unremarkable. But I think this is a nice way to think about it in your mind. Again, you should try to prioritize the past medical history based on relevance to the current admission. So if you've got a patient with a STEMI, mention their cardiac risk factors like their hypertension and their diabetes first. And only include things that you think are really relevant or that could potentially become relevant to the current problem. Again, if your patient had cataract surgery 30 years ago and it was totally uncomplicated, and now they're in for a septic knee, you really don't need to mention the cataract surgery. In internal medicine, it's also good practice to try to give objective measures of disease severity or progression when it's possible. So, for example, your patient has diabetes. You would want to follow that with their most recent A1C, the number of meds they're on, and whether they have any micro or macrovascular complications. Or say they have CKD. What was their most recent GFR? Are they on hemodialysis? If they have COPD, what was their most recent FEV1? Are they on HOMO2? And how many exacerbations have they had in the past year? You get the idea. When possible, try to give objective measures of disease severity. And finally, a very important concept in medicine that I want to highlight that I think a lot of medical students struggle with early on is the difference between a syndrome and a disease. So things like congestive heart failure or cirrhosis, these are syndromes or common presentations that can be caused by many different diseases. So congestive heart failure, that's the syndrome. Congestive heart failure can be caused by ischemic cardiomyopathy or alcoholic cardiomyopathy or valvular heart disease, and the list goes on. And so when you're listing the past medical history, when possible, try your best to give both the syndrome and the disease. All right, medications and allergies. When listing the medications, try to group them by the condition that they're treating. And you can even explicitly say this. So you can say something like the patient is taking 100 milligrams of spironolactone and 40 milligrams of Lasix for treatment of their ascites. Again, prioritize the order in which you mention these in terms of relevance to the current problem. In internal medicine, you're usually going to give doses for each medication. Always mention over-the-counters, herbals, supplements. And for allergies, always include the exact reaction they get when they're exposed to that medication or substance. So if they get penicillin, is it just a rash? Is it, full-blown anaphylaxis? Obviously, this is going to change the way we manage the patient potentially. Moving on to the social history. I really want to emphasize the fact that it's called the social history for a reason. A social history isn't simply whether your patient smokes or drinks, otherwise we just call it habits. The big things in the social history we really want to know are, who are they going home with? This is going to impact your discharge planning. Who's going to make the decisions if things go south and they wind up intubated in the ICU? Obviously, this is very important for advanced care and medical legal reasons. And who should be included in family meetings? For instance, do they have a daughter who's a respirology fellow who wants to be involved in all the discussions and major decisions? And do they have any important ongoing social issues? So for example, were they recently evicted from their home, or maybe their family's having trouble managing their health issues now? These are also extremely important issues surrounding your patient's health, and oftentimes these things can be addressed while your patient is admitted, leading to improved outcomes once the patient is actually discharged home. And finally, yes, it is important to include the patient's occupation and then all of their habits. Okay, family history. In the family history, you should state any family history of relevant conditions, especially in first-degree relatives. For instance, if the patient is presenting with a GI bleed, is there any history of colon cancer or IBD? Or if you have a patient with cardiac chest pain, is there any history of premature cardiac death or any other cardiovascular conditions? You don't have to mention that their second cousin may have had asthma as a child. And it's perfectly fine to say non-contributory if it actually is. Okay, review of systems. So the review of systems actually rarely plays a role in inpatient settings, and it's really more used for outpatient visits. 99% of the time, you'll just say review of systems, non-contributory, because in the acute setting, most positive symptoms will almost always be stated in the HPI. Where it may play a role is in a family practice office where you're doing this general screening exam and you discover that your patient has postmenopausal vaginal bleeding. Another common mistake is to confuse the review of systems for the pertinent negatives which should be in your HPI or vice versa. I think to keep things really simple, the review systems in an acute hospital setting will almost always be non-contributory, and you should include all pertinent negatives in the HPI. Okay, now we'll move on from the history and we'll go into the physical exam. Okay, so when presenting the physical exam, always start with the description of the patient's general appearance. I think this is a frequently neglected thing, but it's a really nice way to give a snapshot of your patient. So describe to your listener exactly what they should expect upon entering the patient's room. Is your patient lying motionless, grimacing, or are they writhing around in pain, or are they sitting up eating dinner while watching TV? Next, always say the vitals. Never say normal or stable. Always mention every single one of the vital signs. And I just want to plug here for the respiratory rate. I think that this is the most neglected vital sign, but it's arguably one of the most important. It's the respiratory rate that predicts mortality and sepsis, not temperature, not heart rate. So please always measure and mention the respiratory rate. And then for the rest of your physical exam, mostly you just want to state your positive findings. The physical exam is generally specific but not sensitive, so positive findings that can help rule in your diagnosis are the most helpful. And like the HPI, mention pertinent negatives. Generally in internal medicine, the order is hands, then head to toe. Only during a neuro exam if it's indicated. Likewise for room and MSK exams. Usually your physical exam will stop with your abdominal exam. Also, a big thing that I see early on in medical students, try to avoid editorializing or overqualifying your physical exam. It's hard as a listener to know what to make of something like, he may have had crackles, but I'm really bad at listening for crackles, so I'm not sure. If something was difficult to assess, just say that you attempted to test it, but that it was difficult to assess, and just leave it at that. Moving on to investigations. So it's very similar to your physical exam. You want to state all your abnormal results, any significant changes from baseline or trends, and all pertinent normals. And finally, the last section of the presentation, your assessment and plan. Aside from the HPI, this is the most important part of your presentation, and it's the part that your staff will be most attentively listening to. This section could be a whole talk in and of itself, and in fact, my colleague has actually created a module which will teach you how to come up with a good assessment and plan. You can find the link to that in the description. But here's the bare bones of what you need to know. So, oftentimes, your assessment and plan will start with a summary. This is 2 or 3 lines that includes only the most essential details from the different sections of your presentation. It also just bails out a listener that wasn't really listening to the rest of your presentation, which unfortunately in medicine isn't all that uncommon. But really it just shows that you know what is most important and what's really going on. After this, you must give your impression. This is also known as a working and differential diagnosis. Your working diagnosis obviously is your leading hypothesis as to what's going on in your patient, and then your differential is all the other things that it likely could be. And it's also a good practice, as you're listing off different diagnoses, to give a few reasons why you think each diagnosis is more or less likely. Finally, after you've given your working and differential diagnosis, it's time to give your plan. In internal medicine, this is usually given in the form of a problem list. This is a list where you identify each of the patient's issues, what you think is causing each issue, and how you're going to manage it. Again, please see the video on how to create a problem list for a more detailed approach. Okay, so that wraps up the first part of this talk. Please go on to part 2 for examples of a bad presentation and a good presentation. And again, a reminder that you can find links to a written guide to the oral presentation, as well as annotated transcriptions of the presentation examples in the description. And finally, again, please see the link in the description to the module on how to create a good assessment and plan.